Welcome to our community broadcasting network featuring the Health and Wellness Best Practices podcast. I'm your host, Dennis Streeter. Today's program will feature a discussion about the current state of Medicaid here in Colorado and what the impact on the program would be if the extreme cuts promoted by the current administration go into effect. The Medicaid program became law in 1965, at the same time Medicare was created, and is administered by the Centers for Medicare and Medicaid Services. Medicaid is the primary program providing comprehensive coverage of health care and long-term services and supports 80 million low-income people in the United States. Medicaid accounts for 1/6 of healthcare spending, with as many as 1 in 5 Americans covered by Medicaid that include low-income and special needs individuals and families. I taped a panel discussion by Medicaid experts explaining how the program works and the impact deep cuts would have if implemented. After the panel discussion, there will be information on how to contact your senators and representative to let them know that you don't want cuts to Medicaid. I want to welcome our panel to go over the information on Medicaid that we have today, as well as the issues that may impact Medicaid if there are significant cuts, as we've heard. Well, why don't we start by having you guys introduce yourselves and your organizations so we have a little context. Edie, you want to take that?
Sure thing, Dennis, and thank you so much for this opportunity. My name is Edie Sun. I'm the Senior Director of External Affairs for the Colorado Behavioral Healthcare Council. We are the statewide membership association representing not-for-profit, community-based providers of mental health and substance use disorder treatment. And CBHC has been around since 1967.
Thank you so much, Dennis, for having us here, and great to see you both, Kelly and Edie. My name is Polly Anderson. I'm the Vice President of Strategy and Financing at the Colorado Community Health Network, or CCHN, and we are the primary care association, or statewide membership association for Colorado's 21 community health centers. And community health centers are nonprofit or public healthcare entities that provide primary medical, dental, and behavioral health care to people who are uninsured and on Medicaid across the state of Colorado.
Great. Thanks, Dennis. So great to be with you and Polly and Edie this morning. My name is Kelly Erbzegger. I serve as the Associate Director of Policy and Advocacy at the Colorado Rural Health Center. We serve dual roles as both Colorado's State Office of Rural Health and Colorado's Rural Health Association. We serve 47 rural and frontier counties across the state, ensuring that the 43 hospitals and over 100 rural clinics across the state can remain sustainable. We've been around since 1991, and much of our team really provides a ton of technical support, again, to ensure that those hospitals can keep their doors open.
Okay, well, that's good background. So you are my experts on Medicaid, and we're going to try to give a real nice in-depth overview of the services Medicaid offers, but also what potential damage the severe cuts that are being recommended by this administration would have on the program. And I think it's going to be very informative. Now, we are here in Colorado, and we're talking about the urban corridor, as well as the rural and frontier areas of Colorado, of which we have significant. But this is really going to be pretty relevant to all 50 states. So this isn't going to be just something that we have to worry about here in Colorado. This is something all states are going to have to deal with. So why don't we start with you guys basically just talking about the type of services that Medicaid is supplying, both in the urban corridor as well as the rural and frontier areas.
Probably good for us to acknowledge that in Colorado, Medicaid is called Health First Colorado, even though us policy wonks tend to just call it Medicaid, but patients and many providers know it as Health First Colorado. It's currently covering about 1.2 million people in Colorado, which is 20% of our state's population, or 1 in 5. So it's a really significant insurance program for the state and a really significant contributor to our healthcare economy, which is a big driver of economic activity in our state. Additionally, Child Health Plan Plus covers about another 93,000 children and pregnant people in Colorado. And it's worth talking about them together because typically any cuts to Medicaid are going to impact that program as well, because they both receive federal funding and are kind of funded from the same part of the federal budget. Together, the two programs, Health First Colorado and CHIP Plus, ensure access to primary, specialty, dental, hospital, behavioral health, and other care to people who otherwise wouldn't be able to afford healthcare insurance or healthcare access, paying out of pocket.
So Medicaid is a huge cornerstone of providing care in rural Colorado. It covers almost 35% of rural Coloradans, and that really does vary by region, with up to over 50% in Costilla County and below 10% in Pitkin County. In rural Colorado, I would say more people are covered by Medicare and Medicaid than urban Coloradans, really due to lower incomes, higher rates of seniors, higher costs of private insurance, and less private insurance coverage options. It really does serve as a vital safety net for Colorado's most vulnerable populations, including children and seniors. So Medicaid's the largest payer for long-term care in rural Colorado, covering about 2/3 of nursing home residents in the state. So without Medicaid, again, most of our rural seniors would not have anywhere to go for long-term care.
And then drilling down into the behavioral health aspect of Medicaid. So first of all, when I say behavioral health, I'm talking about mental health and substance use disorder treatment services. And Medicaid is the largest payer of those services, not only in Colorado, but nationwide. And on average, for CBHC's members, Medicaid accounts for 60% of their revenues. So the majority of people coming through their door are Medicaid enrollees. And close to 30% of people who have received coverage in Colorado since we expanded Medicaid over a decade ago have a mental health or substance use disorder condition. So that Medicaid expansion was especially important in the mental health and substance use disorder treatment space. So Medicaid is absolutely foundational for the people who it is my members' mission to serve. That is adults with serious mental illness and substance use disorder, and children with severe emotional disturbance. We see everybody in our communities, but that is our core population, and they are primarily either on Medicaid or uninsured.
So Medicaid is incredibly important to providing access to maternity care and OB services in rural Colorado. In some regions like the San Luis Valley, Connie, the CEO down at SLV Health, let me know that almost half of the babies born in her hospital are Medicaid enrollees. And, OB services we've seen across the state struggling with their sustainability. And I know we're going to get into this further, but as we see the sustainability of some of our rural facilities erode away, some of those high cost services like OB are going to be some of the first things to go, which will really impact what the maternity care deserts look like across the state and exacerbate an already significant problem. In addition to OB services, and I know Polly talked a little bit about the primary care services, of course, that are covered by Medicaid, but in rural Colorado, because we have reduced access, I think it's really important to point out it's not always about the services that Medicaid covers, but which providers accept Medicaid. That's incredibly important when we're talking about things like behavioral health, specialty care, and dental care, especially in rural Colorado. Because the rates are pretty poor, it can be difficult to get providers to sign on and take those patients. Luckily, in most of our hospitals and clinics, we don't cap Medicaid patients. We take in everyone who comes into our hospitals and clinics, which again can exacerbate already tough financial situations in our rural healthcare facilities.
Well, and I'll just chime in there. So, first of all, I know it's true for my members as well as for Polly's and Kelly's that it is part of their mission to see everybody who walks in their door. You don't check insurance coverage, you take care of people and give them the help that they need at that time. And then my members around the state, the vast majority of them also accept private insurance, and yet Medicaid covers more services and reimburses better for those services than either Medicare or commercial insurance, which I think is really interesting. So we often hear, well, you can offset any losses you have from cuts to your Medicaid population by just taking on more commercially insured people. It doesn't work that way.
Kelly, I can really chime in on that from the community health center perspective, where about 25% of our patients are uninsured. So there's not a lot of other populations to cost shift to. Currently, Medicaid accounts for about 68% of health center revenue. And that's not surprising since we care for 1 in 3 Medicaid enrollees in the state, so a pretty high proportion. And Dennis, I also wanted to chime in. You talked before about how Medicaid was created as part of the war on poverty under the Johnson administration. And I think this is true for my partners here with me too, but Medicaid and the community health center program are really inextricably linked. The community health center program was also created as part of the war on poverty under the Johnson administration. And we're lucky here in Colorado to have Denver Health, which is a huge hospital and health system, but also has a community health center component. And they were the 3rd designated community health center in the country. So kind of a badge of honor that we wear pretty proudly here. And generally, as Medicaid has grown over the years, both through expansions and I think through increasing poverty, the community health center program has grown to continue to care for those folks. We've pretty typically cared for about 1 in 3 Coloradans, no matter the size of the program.
Community mental health centers were actually not created during the Johnson War on Poverty, and as part of those federal initiatives, we were enabled by the very last bill that President Kennedy signed before he was assassinated, and that was the Community Mental Health Treatment Act. But what was really important about that was we were made a creature of federal law, but we were not given any dedicated funding stream. So it was sort of like, this is an important tool as we want to move people out of institutionalized mental health care, but you're on your own. So once Medicaid was created, that did become the crucial funding source for the community mental health centers and behavioral health providers around the country. But we didn't start with that.
Well, here's an interesting side is, and I mean, a lot of people confuse Medicare and Medicaid, and I understand that because the names are so similar. But the Medicaid system and how it's funded is really rather unique because it's a partnership between the federal government and the states. Do you want to explain how that works a little bit?
You're right. It is a partnership, unlike under Medicaid. Unlike under Medicare. What that means in Colorado is that the state of Colorado pays for 50% of the costs associated with Medicaid coverage, and the federal government pays for 50%. That can vary a little bit over time, depending on congressional actions, but it's typically a 50-50 partnership. So when as we think about cuts and how those might come down, Congress is not considering necessarily reducing benefits or eligibility, but as they cut funds out of the program, it pushes the responsibility of funding the Medicaid program further onto states. Most states don't have the ability to absorb the loss of those federal dollars, but I think Colorado is particularly unique because, of course, we have a balanced budget requirement, so we can't deficit spend to make up for federal cuts. We also have some really severe limits on the amount that our budget can grow year over year under the Taxpayer Bill of Rights, or TABOR. And already the Medicaid program is taking up more than a third of the budget. And if we can't make the pie bigger, we can't make spending bigger in Medicaid without impacting other programs. So we are not in a good position in Colorado to absorb federal cuts. And when it comes to our organizations, I think this is pretty universally true. When patients lose Medicaid coverage, we try our best to continue to care for those folks, right? But we do so without a payer source. But that ability is not limited. And already my members, community health centers, have reported about 2/3 of them operating under negative financial margins today. And so as they think about more of their patients losing Medicaid reimbursement, which, as Edie said before, is good reimbursement for us as well, it's very unlikely that they could continue to care for all of the patients they currently see with that loss of reimbursement. What we'd be looking at is more of what we've seen already in the last year or two, which are some small clinic closures or consolidations, some layoffs by some of our larger health centers, particularly in urban areas. Most all are not filling positions via attrition to save money and looking for every opportunity to squeeze and stretch the dollars that they have without cutting access. But that ability is not. It is limited. They cannot continue to absorb more and more cuts without impacting access.
You guys particularly deal with your partners are nonprofits. They are, again, in a different class altogether based on their mandates. Now, funding isn't 100% Medicaid. A lot of your nonprofits have to go and get grants. And how much in relationship to Medicaid is that a shortfall? Again, just generally.
I can tackle that a little bit for community health centers. So I mentioned before that about 25% of our patients are uninsured across the health center network. And they do receive a federal grant, or at least most of them do, to help partially pay for the cost of the uninsured. Those are typically 11 or 12% of a health center's budget compared to having 25% of their patient population be uninsured. So they're not adequate, which makes us highly reliant on Medicaid as the one payer that pays the full cost that you don't have to do extra fundraising for. So it's a pretty significant contributor to our ability to hire and retain staff and see patients, even as folks bump on and off of Medicaid.
You know, nationally, we've seen almost 150 rural hospitals close since 2003. And in rural Colorado right now, 46% of our rural hospitals, so 21 rural hospitals, are currently operating with negative profit margins. And I would argue that this isn't because these are poorly run businesses, but because the business model in and of itself isn't really a business model. Our facilities exist to provide access, and access to a pretty tough patient panel. Folks who are older, have lower incomes and higher acuity. So with 30% of our payer mix being Medicaid, it puts I would say rural Colorado, or our rural healthcare facilities, are really sustained by a patchwork of funding. Medicaid represents roughly 30% of that. We've got another 30% Medicare, some private insurance, but again, we have lower negotiating power with these payers, which puts our providers in a really tricky position. Some of our facilities are lucky enough to get some local tax dollars through a mill levy. Many of them are scrounging if they have the workforce resources to apply for grants, but it really is, it's tough going for our rural facilities. And I'd argue that rural Colorado hasn't seen a closure because of Medicaid expansion. We were an early adopter in 2014, and we saw our uninsured rate drop as low as, what was it, 4.6% in 2023, which really made an impact on the number of folks who are coming into our rural facilities to receive care. I'd argue that Medicare and Medicaid rates aren't always perfect and don't always cover the cost of care, but certainly more so than folks who are coming in without any coverage at all.
On the behavioral health side, as I indicated earlier, on average, Medicaid represents 60% of my members' revenue. So that means for some of them, it's more than that. I've got one member who I believe it's 83% of their revenue. So when we saw numbers of uninsured Coloradans increase over the last 18 months as a result of the end of the COVID-related public health emergency that kept everybody on Medicaid for those 3 years. Some of my members saw the number of people without insurance coming through their doors increase by as much as 50%. So people without insurance and services that are not covered by Medicaid in Colorado are paid in part by the Behavioral Health Administration using block grant dollars that come down from the Federal Substance Abuse and Mental Health Services Administration. And those are matched by state general fund dollars. Well, Colorado was not in a position to increase its general fund contribution to uninsured people needing behavioral health services last year. So BHA wasn't able to fill that gap. Those federal grants were not changing. Now those federal grants are in jeopardy as the Substance Abuse and Mental Health Services Administration is being changed, streamlined, reduced, and folded into the Administration for a Healthy America. So what this means is that portion of the funding pie that used to be there to cover services provided to uninsured people who needed mental health and substance use disorder treatment isn't there in the way that it was. Now, happily, Polly, Kelly, and I and other colleagues from the Safety Net Collaborative and the Colorado Hospital Association were able to work with legislators over this last session to pass a bill that enabled a new short-term funding stream to help cover some of the cost of care for people without insurance, but it is not a long-term stable source of funding. So as we look at these potential Medicaid cuts coming from the federal government, we are all very concerned about the impacts on our members' ability to continue to serve the most vulnerable people in their communities.
Yeah, I can really chime in on that and say that while that was a huge victory to get that short-term funding, it was to plug holes that already exist in our systems. And not all safety net providers were part of that work and are eligible for that fund. So some folks were left out of that entirely. So Correct. If we look at additional Medicaid cuts, the hole's going to be bigger and the funds are really not adequate. And we're really talking about some of our most vulnerable Coloradans here. I don't know if we've really painted a picture of the type of folks that are eligible for Medicaid, but we're talking about working individuals who are making just $20,040 a year. We're talking about somebody who got laid off from their job last week and is still looking, who gets enrolled in Medicaid to tide them over while they're looking for work. A family of four can only make $44,304 to qualify for Medicaid. So we're talking about some incredibly low income folks, pregnant individuals making slightly more than that. And then I mentioned before what an important program this is for the disabled, both who are SSI eligible and disabled individuals who are working and are able to qualify and buy into Medicaid, because that is the best health insurance coverage to really meet their robust needs that commercial insurance often cannot do because of the breadth and depth of challenges and coverage needs that some disabled individuals have.
The impact of COVID on our mental health in this state and in all states is significant. And that's where we saw a huge jump in need and usage. So, as probably, as you said, this was just to plug up some holes. Well, those holes were created by the unbelievable situation that we went through with COVID. And now they're talking about cutting. And it's just insane.
Yeah, I couldn't agree more. And I do want to give Kelly an opportunity to chime in here with some of the specific rural impacts. But to the point you were just making, Dennis, about the impact of COVID on individuals' need for mental health and substance use disorder treatment. Yes, it did escalate it. And then as we watched people lose their Medicaid coverage as a result of what we call the unwinding of what had been that public health emergency, and we saw the challenges that posed for people to retain or regain their Medicaid coverage, and then the impact that had on their mental health. It has been absolutely huge, because you think about people who change addresses frequently or who are homeless. That's a big portion of the population my folks see, because those people are the ones many of them are the ones with serious mental illness and substance use disorder. It's not easy for them to navigate challenging websites and enrollment and eligibility determination processes. And as we look ahead and we think about some of the changes that are going to potentially be made at the federal level, those people who are already in jeopardy are going to be in even greater jeopardy.
I just wanted to add a little bit about to the question of who is the Medicaid population, and I guess who is deserving of those benefits. And I think it's really important to point out that children across the state represent the largest share of Medicaid beneficiaries, and actually seniors and folks with disability represent the largest share of the costs. So there's no way that you can make cuts to Medicaid without impacting children, seniors, and folks with disabilities, who I said earlier disproportionately depend on Medicaid for nursing home, long-term care services, et cetera. Seniors account for 2/3 of the Medicaid spending, primarily due to their longer-term care needs.
The issue of people getting services does have a huge impact on our economies, on the state and federal economies. An example that I can give really quickly is, I did an interview with the Colorado Cross Disability Coalition. And I learned so much about how people with disabilities are able to stay and live independently because of Medicaid, what Medicaid supplies. Well, what would happen, and again, this is just one example, what would happen if there were cuts and suddenly you had people thrown off of Medicaid and not able to get the services? These people that are living at home, that have ramps built, that have, special services for the blind and the deaf and stuff like that. If that diminishes and goes away, these people are going to have to be institutionalized. So you're taking their freedom away. But look at the cost of that. So, again, we're looking at a crisis if Medicaid is cut. If anything, it should be expanded in the richest country in the world. So, again, I know you guys would have a lot of examples of how Medicaid cuts would impact the general economy.
So Let me kick this off and then I'll turn to my colleagues to chime in with their own perspectives. So first of all, think about this from the standpoint of a return on investment. On the behavioral health side, there's a study from a few years ago showing that every dollar invested in community behavioral health through Medicaid reimbursement or the funding from the state and the feds to cover care provided to the uninsured yields $4 in savings from avoided emergency room utilization, incarceration, homelessness. Then you've got the ripple effects from when somebody is getting treatment, they are more likely to be able to get and hold down a job. They are more likely to be able to contribute to their community, to their economy, to that economy. So that's one example of it. I know Kelly's got some really detailed examples from the rural health hospital side.
Sure. Thanks for that, Edie. And, we like to say in rural healthcare that a rural hospital or a clinic, it looks like a three-legged stool in rural communities. So usually you've got a rural healthcare facility, municipal government, and if you're lucky, some sort of additional industry. But if you pull one of those out, a rural community cannot survive. Folks can't raise their families there, they can't age in place, they can't start businesses. And in a state like Colorado, where we depend on rural Colorado for so much of our statewide economy, when we look at ag, energy, our huge tourism industry, it's critical to ensure that we have rural healthcare facilities available not only for folks who live there, but folks who are also visiting. One rural physician provides $1.2 million in economic impact every year and supports an additional 28 jobs. That's incredible in our rural communities. And I think it's really important to point out, too, that when we cut Medicaid in rural community, in terms of healthcare access, it's not just folks on Medicaid who are impacted, because typically there's only one hospital or clinic in a community. We have entire counties across the state that have no hospital, 17 of them. So in a rural hospital, if they're already struggling financially, which, like I said, 46% of them are, and we see cuts to Medicaid, we're going to see service reductions. We're going to see layoffs to the workforce. We're going to see reductions in hours, and that impacts everyone. Like I said, OB access is already pretty limited in rural Colorado. Specialty care, extended hours, some of those more high dollar items will be the first things to go when we see significant cuts to Medicaid, which impacts folks who are on different types of insurance, Medicare, Medicaid, all of those folks will be impacted. In terms of the economic development, rural economies really do depend on rural healthcare. And we will see communities shutter. Their inability to grow and flourish will be significantly impacted by cuts to healthcare.
At least similar story with community health centers across the state. So community health centers employ about 7,000 people across the state, and they're strategically located in areas where there are access issues or higher concentrations of poverty, or both. So in addition to providing healthcare access in those key communities, they're providing good jobs in high need areas and contributing to local economies. I know that's true for all of our memberships. Cuts to Medicaid are cuts to health centers. Cuts to Medicaid are cuts to rural health centers. Cuts to Medicaid are cuts to ED's community behavioral health providers. And they are cuts to the local economies and the communities that we all enjoy visiting and hearing about across our state. Medicaid and healthcare spending is a huge driver and employer of our economies. And for the dollars spent at the health center, for the wages that are paid, and then respent at the dry cleaners, at the grocery store, at kids' daycares, et cetera, they really exponentially flow through communities. And so if we're forced to employ fewer people, there'll be fewer dollars flowing in these high need communities across the state. So I just couldn't agree with Kelly more that the impacts to Medicaid cuts are so far beyond the devastating impact they're going to have on the individual patients and even on provider groups like ours.
Yeah. And I really also want to pick up on Kelly's point about that. My introduction to healthcare policy was in 1991, where I was working for a local think tank, and the very first program I worked on was an economic development initiative in rural Colorado related to healthcare and connecting the dots between having a local hospital in a rural area and having a thriving economy. So we've recognized this for decades. And the fact that there is potential short-sighted policymaking coming out of Washington that is going to undercut that. And as Polly indicated, it's going to happen in the rural communities. It's going to happen in all of our communities around the state. It's frankly heartbreaking.
And if I could add a couple specific statistics that we have around what that economic impact looks like. So when a single rural hospital closes, 220 hospital jobs on average are lost. Additionally, 72 non-hospital jobs, so other community jobs, are also lost. We see a decrease in per capita income. We see, of course, an increase in the community unemployment rate. But on the healthcare side of things, it exacerbates these already significant disparities in healthcare access. Folks have to travel 11 to 15 minutes further. That's just EMS transport, 11 to 15 minutes further. On average, patients are going to have to travel at least 20 miles further to access a healthcare facility.
As usual, I learned a lot, like I always do. So I think we can wrap this up with some final thoughts. So Edie, you want to lead that off?
Sure, Dennis. Thank you very much for the opportunity. I think it's crucial for everyone to understand that even though the bill continues to move very quickly, we cannot let our foot off the gas in terms of communicating with our congressional delegation. It's in the Senate right now. Reach out to Senators Hickenlooper and Bennett. Tell them about your concerns. It's vitally important that they have a critical mass of constituent communications to point to so they can say, I continue to hear from Coloradans about their concerns about this. And at the same time, even though the bill has passed out of the House, whatever changes get made in the Senate will have to go back to the House for concurrence. So all 8 members of our congressional delegation also need to hear from their constituents about their concerns about the version of the bill that passed out of the House. We have to keep the pressure on.
Don't accept the line that these cuts aren't going to harm the base of Medicaid and that they're about fraud, waste, and abuse. The cuts being proposed are going to complicate Medicaid enrollment and re-enrollment such that we're going to lose a big chunk of our safety net. Individuals who are disabled, children, people who are temporarily unemployed and in need of health coverage are not going to be able to get the care that they need. Our own state estimates that implementing some of the work requirement system changes will cost $57 million. That sounds to me like fraud, waste, and abuse, unnecessary spending to keep individuals that are already eligible for programs that are already difficult to get enrolled in and to stay enrolled in. Don't accept that as an answer. Fraud, waste, and abuse is a cover for wanting to reduce the safety net and push folks out on their own where they won't be able to afford the high cost of health insurance and they'll have to delay needed care, which is going to result in unneeded suffering, damage to the organizations that are taking care of these folks, and higher ultimately rates of health insurance and healthcare costs as we lose the ability to cost shift, and folks will be responsible and required to raise their own prices in order to make up for these revenue losses.
Thanks for that, Polly. And I'll add that protecting Medicaid protects rural Colorado. Medicaid is vital to supporting the already fragile rural health system across rural Colorado. It ensures that some of our state's most vulnerable patients have access to affordable care close to home. it also underpins the economies of so many of our rural communities across the state. So again, I'll say it again, protecting Medicaid protects rural Colorado.
This whole idea that Medicaid cuts will take care of, waste, fraud, and abuse is absolutely ridiculous. Anybody who knows how the system works knows that it's just not true. All right. Well, again, I really appreciate the three of you coming on and sharing this information. And I absolutely want to invite you to come back and discuss this issue and other issues that you're working with on the health and wellness side. So thanks again for that. As our panel said, it's critically important for our senators and representatives to hear from us on this important issue. To contact your elected member of Congress, go to congress.gov. Once there, go to Contact Your Member and fill in your address. That will take you to your members page with links to allow you to send them a message directly. Be sure to share this information with friends and family in other states as well, so our voices can be heard across the country. Again, I want to thank our panel for this great presentation, and a special thanks to Edie Sun for coming up with the idea and putting together the panel. I look forward to doing this again with them and getting updates.